Assalamu alaikum wa rahmatullah. Welcome back, everyone. We'll start our next talk, Adrenal Gland, by Dr. Abdullah Alghamdi. Dr. Abdullah Alghamdi is a breast and endocrine surgeon at Prince Sultan Military Medical City. Welcome, Dr. Abdullah. It's a pleasure to have you with us here tonight. And please, the floor is yours.
بسم الله الرحمن الرحيم. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
الصوت واضح؟
نعم، الصوت والصورة. تفضل دكتور.
Can we start?
إيه أكيد، تفضل.
بسم الله. So I'm going to highlight the disorders of adrenal glands that's mainly related to us as a surgeon. So it's a big topic, but I think for surgeon, we have to deal with the conditions that end up needing surgery. Other conditions mainly will be dealt by the internal medicine or the endocrinologist. So to start with, there are two adrenal glands, right and left. The shape of the glands are different, could be V shape, Y shape, H shape, pyramidal shape, and histologically there are two different histological types of the adrenal gland, the cortex and the medulla. The cortex, the outer layer is the zona glomerulosa, the middle layer is the zona vesiculata, and the inner layer is the zona reticularis. And each zone of this, the cortex secretes different hormones. So zona glomerulosa secrete the aldosterone, vesiculata secrete the cortisol, reticularis secretes mainly androgen. The other part, histological part of the adrenal gland is the medulla and secretes the catecholamines. So this is the adrenal gland and the control of the adrenal gland. Each part of the adrenal gland is under control of different pathway. So like the adrenal medulla, it's a direct it's under direct effect of the sympathetic nervous system. So whenever the sympathetic nervous system is stimulated, it will signals to the adrenal medulla that secretes the catecholamines. While in the zona glomerulosa, it's under the direct effect of the renin-angiotensin aldosterone system. So in cases of low renal perfusion or low sodium, this will stimulate the kidneys to release the renin that convert the angiotensinogen to angiotensin 1 through the ACE. That this will be converted to angiotensin 2, and this one has a direct effect on the zona glomerulosa to secrete aldosterone, and the main function of the aldosterone to promote sodium retention and wasting of the potassium. The other two layers of the adrenal cortex, the fasciculata and reticularis, it's under the control of hypothalamic pituitary adrenal axis. So ACTH have a direct effect on both the fasciculata and reticularis that both secrete the cortisol and the androgen. It's very important to know the metabolites of the catecholamines, so we'll be able to understand the screening and diagnostic test for the pheochromocytoma later. So catecholamines, we have the dopamine, norepinephrine, and epinephrine. These are the primary catecholamines, and their metabolites mainly norepinephrine and epinephrine. So when we we'll discuss this in details at when we discuss the pheochromocytoma. Anatomically, the main important thing that we have, so both share the same arterial blood supply from the inferior phrenic arteries, branches from the aorta and branches from the renal artery. However, the difference is the main difference is the venous drainage. The left adrenal, the venous drainage goes direct to the renal vein, left renal vein, while the right one goes to the IVC. So we'll start with the diseases that result from the excess secretion of the hormones from the pituitary gland, from the adrenal gland. The first thing is the Cushing syndrome. So Cushing syndrome is a quite common, but most of the patients will present it as subclinical. And we have many causes of the Cushing, either endogenous or exogenous. And by far, exogenous causes more than endogenous. The most common cause for endogenous Cushing syndrome is the pituitary adenoma. 25% is due to adrenal adenomas, and 10% due to ectopic sources like small cell lung cancer or non-pituitary ACTH producing tumor. As we know, there are the high cortisol level. It affects many organs in the body. And so the symptoms and signs will be distributed through all the body. So loss of hair, moon face, CNS irritability, gynecomastia, central obesity, osteoporosis, and these are common symptoms and signs we see in Cushing. And the most important point in Cushing is the diagnosis. So whenever we suspect Cushing syndrome in a patient, so we have to start with a screening test. And we have actually three screening tests. The first one is 24-hour urine free cortisol. So we ask the patient to collect the urine and we check the cortisol level. If it's more than 3 times than the upper normal, this is a highly suggestive Cushing. The other screening test is the low-dose dexamethasone suppression test. So we we instruct the patient to take 2 milligrams of dexamethasone at 11 p.m. and in the morning at 8 to 9 o'clock. We measure the serum cortisol. If it is less than 50, this would exclude Cushing. The other screening test is the serum, saliva salivary cortisol level. So again, if it's more than 3 times, this will be suggestive of Cushing. So if any of those screening, so we need only one of those screening tests to be done. If it is suggestive Cushing, is the next step is we have to know, is it ACTH dependent or ACTH independent? So at this time, we check the ACTH level. So if the level is low, it means that the adrenal gland secreting too much of cortisol, and this will lead to a negative feedback to the pituitary gland. This is a syndrome, Cushing syndrome. In Cushing disease, we see the ACTH is very high. So the next step, so now for us as surgeon, if it's low, this is Cushing syndrome, and we might need surgery at the end. But if it's high, that's maybe endocrine or neurosurgeon. So if the ACTH is high, we have to know, is it the source, is it pituitary or ectopic? So in this case, we have to order the high dose dexamethasone suppression test. And this is actually, we do the baseline dexamethasone, and we give the patient 8 milligram dexamethasone at night, and in the morning we check the cortisol level. If it drops by 50% or more, this is pituitary, because high dexamethasone can suppress the normal pathway. However, if it's ectopic, high dose of dexamethasone will not affect the ACTH level. So after we diagnose the Cushing syndrome, the next step is to do the images. So if we end up having Cushing syndrome, next step is to do abdominal CT scan to localize the adrenal adenoma. Is it right or left? For Cushing disease, we end up ordering an MRI for the pituitary. And for ectopic ACTH dependent Cushing, we'll need to do a CT chest and abdomen to scan for lung cancer or abdominal tumor. Of course, for us, if we end up having Cushing syndrome secondary to unilateral adrenal mass or adenoma, we'll end up having surgery. The second most common disease resulted from high secretion of the adrenal hormones is the primary hyperaldosteronism. So it is quite common, not as we thought before. So about 5 to 15% of hypertensive usually secondary to primary hyperaldosteronism. And there are many subtypes of primary hyperaldosteronism. The most common is the idiopathic hyperaldosteronism. About 30% is the aldosterone-producing adenoma, and very rare to see primary unilateral adrenal hyperplasia or adrenocortical carcinoma. So most patients of primary hyperaldosteronism, if they are presented to us, they may present as a hypertension or hypokalemia. So, but hypokalemia, absence of hypokalemia does not exclude hyperaldosteronism. And sometimes patient will present with the muscle weakness, and that's mainly because of severe hypokalemia that lead to the muscle weakness. So now, if we suspect primary hyperaldosteronism, then we have to order for serum potassium, sodium, and picarb. And the screening test for primary hyperaldosteronism is the aldorenin ratio. So if we check the ratio and it's more than 20, then we suspect primary hyperaldosteronism. And then we have the confirmatory test for the primary hyperaldosteronism. There are many different confirmatory tests. The most common the endocrinologist usually order is the saline infusion test. So the patient will be given 2 liters of normal saline over 4 hours, and before the at the end of the test, they will measure the aldosterone level. So the normal response, if you give those normal patient high volume of normal saline, the aldosterone will be low. And so if it's more than 10, it's primary hyperaldosteronism is very unlikely. So after we diagnose the primary hyperaldosteronism, then we have to localize the cause. You need a CT scan, which is the initial study that we need to order. And as we know, the most common type is idiopathic, and then adenoma and hyperplasia. So CT scan might diagnose the underlying cause. Then after we do the CT scan, and even we localize the one adrenal adenoma or mass, then we need to confirm the source of the high aldosterone level by doing adrenal vein sampling. And in the literature, the indication of the adrenal vein sampling are variable and different from one center to another one. But we follow the Mayo Clinic criteria. So they do the adrenal vein sampling when the CT scan is normal, or if there is bilateral abnormalities or nodules, or if there is a unilateral abnormality, but the patient is young, less than 40. I mean, the patient is over 40. So the treatment for unilateral adrenal aldosterone adenoma is surgery. And for bilateral adrenal hyperplasia or bilateral nodule, we refer patient to endocrinologist for medical treatment. And we can expect those patients who will their high blood pressure will be back to normal after surgery by measuring the aldosterone resolution score, which include the number of antihypertensive medication, body mass index, years of hypertension, and if the patient is male or female. So the higher score, the better outcome. The other pathology related from high secretion of adrenal glands, the pheochromocytoma, it's about 0.1% of all hypertensive patients. And it's rare, and we investigate only if clinically suspected. Signs, if the patient have signs or symptoms of pheochromocytomas, usually patient will present with a severe hypertension or hypertensive crisis or refractory hypertension. And if we found an incidentuloma and the patient having some symptoms of the pheochromocytoma, these are the indication of suspecting the pheo and investigating for pheochromocytoma. So the usual symptoms start with hypertension, headache, sweating, palpitation, or pallor, and usually it comes as a bruxism. The classical triad of pheochromocytoma, headache, sweating, palpitation. So lack of all the those signs is usually or virtually excluded diagnosis of pheo. There are different other symptoms like nausea, vomiting, abdominal pain, chest pain, which are non-specific. So in pheochromocytoma, as we know, there is a rule of 10% extraadrenal, 10 in children, 10% familiar, 10% bilateral, and it tends to recur in 10% of patients, 10% malignant, and 10% discovered incidentally. So there are different familial pheo, like in MIN2A, MIN2B, von Hippel-Lindau syndrome, neurofibromatosis 1, and familial paraganglionoma. So how do you diagnose pheochromocytoma? Usually we either we collect the urine for 24-hour urine collection for catecholamines or metanephrine. The other the test that we can help to diagnose pheochromocytoma is the plasma metanephrine or metanephrine. So if the result came at the threefold more than normal, that's indicated for a pheochromocytoma. So how do we localize for pheochromocytoma? Usually we start a CT scan. It's very sensitive, and the problem is the extraadrenal or paraganglioma is not sensitive for the CT scan. So if we did a CT scan and there is nothing in the adrenal, then we need an MRI, MIBG scan, and PET scan for paraganglioma or ectopic pheochromocytoma. Treatment of pheochromocytoma, usually it's we start with a medical treatment to control the symptoms, and usually this takes 2 to 3 weeks. And treatment for a definitive treatment of pheochromocytoma is surgery. So how do we prepare the patient? Usually we start with the alpha blocker, either selective or non-selective. The non-selective is phenixabenzamine for a week or 10 days. And if the patient started to have a beta blocker or postural hypertension, then we'll add the beta blocker. If the patient is having allergy to the alpha blocker, then the second choice is a calcium channel blocker. And if the patient not improve or control with the calcium channel blocker, then metyrosine is another option. So after we control the patient's symptoms, and we're preparing for surgery and laparoscopic adrenalectomy. So after we finish from the Cushing, primary hyperaldosteronism and pheochromocytoma, which usually patient will be investigated and referred to us from the endocrinologist. For us as a surgeon, the most presenting adrenal problem will present it as an adrenal incidentoma. So we order a CT scan for the patient, and incidentally you find an adrenal mass. So the incidence of the adrenal incidentoma, it's variable from 1 to 5% of all abdominal CT scan. And we have two missions here when we found an adrenal incidentoma. The first thing is the mass or adrenal mass, is it benign or malignant? The other thing is this lesion functioning or not functioning. So whenever we have adrenal incidentoma, we should have the differential diagnosis. It's either benign or malignant. Benign, the most common is the adrenal adenoma, hyperplasia, hemorrhage, or very rare to have infectious disease cause. The malignant cause is carcinoma. However, metastasis is more common, the primary adrenocortical carcinoma. So how do we work up a patient with adrenal incidentoma? Detailed history and examination. So we look for all the symptom signs of Cushing, phew, and primary hyperaldosteronism. And then we sit with the radiologist to discuss the CT finding. So in the CT scan, there are features of benign adrenal mass. So if the mass is homogeneous, size less than 4 centimeters, the borders are smooth, and there is no invasion, and the attenuation is less than 10 Hounsfield, that goes with the benign adrenal mass. So 70% of adrenal adenoma are lipid rich, and 30% is lipid poor. So lipid rich means that the cells is full of intracytoplasmic lipid. So in the CT scan, the Hounsfield will be 10 or less. However, the problem is the lipid poor, the Hounsfield usually will be greater than 10. And so whenever we have the Hounsfield is more than 10, we need a CT scan of adrenal protocol. And the adrenal protocol, usually we do the CT scan before without contrast. Then we do give the patient a contrast, and 1 minute, we check the enhancement at 1 minute and 15 minutes. And we can check the absolute enhancement washout. Usually the adenoma, it has a rapid washout. If it's more than 60%, that goes with a lipid poor adenoma. And for relative enhancement washout, it's more than 40%. So this goes with adenoma as well. Other imaging studies, MRI, and PET scan, but usually very rare we end up having the MRI or PET scan. Usually CT scan and adrenal protocol is sufficient to diagnose the adrenal incidentoma. Then we do the biochemical workup to know is it functioning or non-functioning. As we mentioned before, we have an screening for primary hyperaldosteronism is the aldorenin ratio, Cushing syndrome, either 24-hour urine collection for cortisol or low-dose dexamethasone test. For pheochromocytoma, we usually order the 24-hour urine for catecholamines or its metabolites. So do we need to do a biopsy for adrenal mass? The answer is no. And it's only if we are, if the patient has a primary malignancy and we think this is metastasis, so just to confirm the metastasis, or the patient has adrenal cortical carcinoma, not for surgery. So just we have to confirm the diagnosis. Otherwise, we need to do surgery for those patients without a biopsy. So treatment for adrenal incidentoma, if it's functioning, it's or the size of the nodule is more than a centimeter, or suspicious for carcinoma, so usually we need to do surgery, adrenalectomy. For those who has no non-functioning adenoma, then we need to follow them up. Usually we repeat the biochemical workup in 6 to 12 months for almost 4 years. And the imaging study we repeat it in 6 to 12 months for 2 years. If the nodule is stable, so we don't need to follow them up again. So I have a questions here. ممكن بس نعملها so can you answer نعمل voting الآن؟
نعم دكتور، الآن ولا نقرأ السؤال الأول؟
طيب 50-year-old female patient, known case of hypertension, diabetes, poorly controlled blood sugar, complaining of generalized weakness and weight gain over the last 6 months. On examination, blood pressure 140/84, heart rate 88, and she's obese and has striae over both thighs. Routine blood workup was normal. She has an iron deficiency anemia. What is the most opportunistic step? Okay, so about 56% low dose dexamethasone test, which is true. So this patient presented with symptoms and signs suggestive of Cushing. So we have to do a screening test for the Cushing, which is low dose dexamethasone suppression test. So now the same patient, serum cortisol after low dose dexamethasone test is 520. The normal is 138 to 635. What is the most likely diagnosis? So 35 Cushing syndrome, 26% exogenous Cushing. Okay. So the answer is Cushing syndrome, because this is the low dose serum dexamethasone test is positive and should be suppressed. If you do give dexamethasone, next day you should the dexamethasone less than 50 actually. If it's more than 50, so we suspect Cushing. So the same patient, so now we are suspecting Cushing. The low dose dexamethasone test is positive. So what is the next step? So 50% plasma ACTH, 24% high density. So now we have to know, is it an ACTH dependent or ACTH independent? So now if the ACTH is very low, it means that the adrenal is secreting ACTH that suppresses the adrenal, the pituitary. So the next step is the ACTH. So plasma ACTH level is 0.5. The normal range is between 6 to 76. What is the next step in the management? Okay, so this is a Cushing syndrome. We have to localize the, is it right or left adrenal adenomas? So we ordered for the patient CT scan, and the result came as 2 by 3 centimeter left adrenal mass. The Hounsfield is 8. What is the next step in the management? So laparoscopic adrenalectomy, medical, 20% medical adrenalectomy. So this is the CT scan result. It's unilateral adrenal mass, looks like adenoma, and by investigation, it's functioning. So we need to do a laparoscopic adrenalectomy for this patient. So patient was taken to the OR, and uneventful laparoscopic adrenalectomy was done. 8 hours after surgery, her blood pressure is 90/60, heart rate is 110, hemoglobin 14. Before the surgery was 14.5. Now, what is the most likely diagnosis of this patient? Okay, 98% acute adrenal insufficiency. So how do you confirm the diagnosis of acute adrenal insufficiency? Short sign-acting test. So we give the patient synthetic ACTH, and we check the cortisol level 30 minutes later. Usually, it should the cortisol should be increased than more than 50% than the baseline. If it's not, this is the it's confirmed the acute adrenal insufficiency. So, in summary, it's very common to see patient who deal with a patient with adrenal incident trauma. So whenever we have a patient with adrenal incident trauma, we take a history, do a physical examination, which most of the time is not relevant, but we could find some symptoms or signs that direct our management. And the most important thing is to read the CT scan. So now, if the adrenal mass is 4 centimeters or more, so most likely this patient will end up having adrenalectomy. And we have just to make sure, is this functioning or not? and the most important thing is to rule out few. So after the size, we check with the Hounsfield, enhanced CT scan, the Hounsfield. If it is less than 10 centimeter, 10 Hounsfield, then this cannot be few chromocytoma. So few chromocytoma, Hounsfield usually more than 10. And so we don't need to work those, to do the screening for the few chromoscytoma if the Hounsfield is less than 10. If the patient is normotensive and the potassium is normal, usually we don't need to do the screening for the Cone syndrome. However, Cushing is very common to have Cushing, and which is subclinical. So we need to, on all patients with adrenal syndrome, we have to do a screening test for Cushing surgery. Adenoma that has, adrenal mass that has features of malignancy or non-specific, or the Hounsfield more than 20, even if it's small than less than 4 centimeter, then it end up having surgery. أحد عنده أسئلة يا شباب؟ طيب عبد الرحمن يسأل عن إنه is there any cut off size for laparoscopic or open even in benign? Well, in benign, if you have the experience and you can do it, it can be done up to 18 centimeter. So there is no contraindication for trial of laparoscopic. For cancer, usually if you suspect cancer, usually it's better to do it open, even for smaller. But in some centers now, they are doing laparoscopic adrenalectomy even for cancer that has no direct invasion to surrounding structures. Post-operative medical management should be continued for how long? For which patient? You mean the Cone syndrome? For few chromocytoma, usually we stop the antihypertensive immediately after surgery, and that should be monitored. The patient should be monitored during in the ICU for the first 24 hours. For the cones, we go back now to the aldosterone resolution criteria. If the criteria is very high, like 4 or 5, most likely those patients will end having no treatment for hypertension, but it takes time. It takes months, weeks to months. So we reduce the antihypertensive medication gradually. For incident trauma, should we go with the plasma metanephrine or urine metanephrine? So you can choose the plasma metanephrine or 24-hour urine metanephrine. Even plasma catecholamines is an option and can be diagnostic. So in the literature, both are okay. For MCQ, which one to start, plasma meta or urine meta? Both are okay. It's diagnostic for a few. في أي أسئلة يا شباب؟ An MCQ usually will put both. So plasma, you use catecholamines, epinephrine, and norepinephrine for the plasma is more sensitive than the metabolites, but for the urine, use the catecholamine, the metabolites of the catecholamine. في أي سؤال ثاني يا شباب؟
Thank you, Dr. Abdullah, for this amazing talk.